I'm probably going to go to the other end. Isla's been taking the wide picture, and I'm a qualitative researcher, so I'm going to narrow us in and talk about a particular project and just, I hope, give you a flavour of how we used action research in that project, and then, you know, ideas going forward about how we want to take that forward and how, you know, some of you might be interested in taking it forward or collaborating with us in some way. So I'm going to talk about a parent training project for children with cerebral palsy in Bangladesh. I'm just going to give you a tiny little bit of background to the project, why it came about, and then I'm going to talk about the key findings and the use of the kind of mixed methods. I'll try not to go into too much detail, but you can ask questions for more detail if you want to. And then the development, which was the most important thing, which was the development of a training package. So here, for anybody at the end, we've got a training package for parents that's come out of the project. And at the moment, it's been downloaded and being used in more than about 150 organisations across more than about 40 countries. And we launched it in July. And as any of you know, working in universities, we're not very good at promoting these things, so we're quite surprised actually by the uptake. And at the moment it's being translated into Spanish, Hindi, Bangla and Arabic. So that's quite amazing. We're quite surprised. Pleasantly surprised. So just flicking back to Isla's project, they did this large-scale survey. And they found that of the prevalence of 9 per 1,000 children with a moderate or severe impairment, they found that 40% of these cases were children with cerebral palsy. So it was the main reason why children had a disability. And then what they found that, ethically, if you do a survey, you have to offer a service. Okay, and the funder, CBM, is a disability organisation, and no survey without a service. And there were no services. So there was some money left in the project, and the idea was, well, if there's no services, what are we going to do about that? So if you look in Bangladesh, you've got a population of about 155 million. So anybody works in Bangladesh? Right, I've got one. So anybody want to guess at how many occupational therapists there are for a start in Bangladesh for that population? Go on, hazard a guess, someone be brave. Anne, you've worked in Bangladesh.
Well, I've only been short times, but I met hardly any.
Okay, so about 145. Okay. I texted my friend my friend is an OT who I work with on this project, and he's an OT. Unfortunately, he was doing a PhD at the school with us, and he's texted me the latest figures today. Speech and language therapists for the whole country, 60. Okay, physios, bit more, 1,300. Okay, then you go to the fact that you want to work in rural Bangladesh. Okay, and you can't get anybody to work in rural Bangladesh, so we really struggled. We managed to get a physio to work with us on the project, and about halfway through we managed to kind of bribe by knowing somebody who knew somebody to get a speech and language therapist to work with us on the project. So that's just to give you a flavour of how hard it is to get people, specialist services as you would know it, particularly in the more rural areas of Bangladesh. So in that context, and knowing all of that, we thought, what are we going to be able to offer these families? So the idea was that we would develop a parent training package that was relevant to families, was acceptable to families, and was evidence-based. And that the idea is that you could empower families to take care of their child with a disability, with cerebral palsy. And we wanted to make it an action research project. So the emphasis was on the fact that we had to deliver to these families anyway, in these 2 districts where we are working. So we actually had just over 150 families identified in these 2 districts that we had to deliver to in a year period. But during that delivery, we had to develop a parent training material that was relevant to them, acceptable to them, and evidence-based. So we did some very initial baseline interviews. We followed case studies over the course of the year, We did interviews, we added in interviews with children, and we did lots of reflection sessions and everything else with the community workers and staff. But to start with, I think it's important to say we also did an important literature review at the beginning to see what was already out there, which I was shocked to say wasn't very much, actually. There wasn't very much good stuff that was developed in lower middle income countries that was focusing on empowering of parents in a community type model. Hambisela was a material from South Africa, a very small NGO in South Africa who had done some work with parent groups. And they were very happy for us to take some of their material, modify it, test it, add to it, take away from it. And then obviously we brought in other good materials that were available. But I have to say, having come in from the kind of HIV sexual health world more, I was quite shocked by how little there was there in comparison. And I think that probably goes back to a lot to do with funding. So we delivered to 14 parent groups over the year. We offered them a modular training course, and we did follow-up home visits. 153 children, we had about 10 that died over the 18 months actually, and their age range was 2 to 14 years. I think that's quite important, the age range, because I think initially there was a big push towards us focusing on much younger children, earlier intervention, better outcomes. And I can remember early days sitting around an advisory group meeting, people really wanted to push down the age, particularly people who were orthopaedic surgeons or clinicians who knew that earlier intervention was going to be better for us. And I was coming from a community perspective, and I was saying, but if you're going into work in a community, you can't turn people away. And I'm glad that we didn't, because actually we got some very good case study material of older children where there were real changes in 12, 13, 14-year-olds from very simple interventions. So, and I think it's worth, just to give you an idea, that's a picture of one of our groups. I can tell you that nobody walked more than about 15 minutes to get to our groups, and our average group size was 10 to 12 children per group. So that gives you an idea of the amount of cerebral palsy existing in that village. And I think the most kind of humbling thing was these people arriving at groups who had never met the other person, didn't realise the other person in their village had a child with cerebral palsy, and then going home and sharing a rickshaw home together. So I think that was a very important component of it. All this stuff that we're doing on better feeding and positioning and everything else. But a lot of it was actually about meeting other parents with a child with CP. So just a little bit about our findings from the case studies. I'm a qualitative person, but quite a lot of pressure to do some quantitative stuff in there. So we did do a quality of life measure, for those of you who are familiar with it. So it looks at a whole different domains, and we wanted to look at the primary caregiver and the impact of caring for a child with cerebral palsy on the family. And it looked at a whole range of issues, psychosocial health issues, and we compared it to matched families in the same villages who didn't have a child with a disability. And it was, you perhaps not be surprised to see, but it is very powerful. Across all domains, it was massively statistically significant that a family, a caregiver with a child with cerebral palsy had a very significantly lower quality of life score. So that's just to give you an idea on emotional functioning here. I feel anxious, far left top. I feel sad. I feel angry. I feel frustrated. I feel helpless or hopeless. In the blue is your family with a child with a disability. And in the red, you've got a family that didn't have a disability. Yeah, so you can just, if I look at this bottom one here, this is the family of a child with a disability. I feel helpless or hopeless, almost always, often, sometimes. And then the red is the family without a child with a disability. So very powerful. And what I liked about doing this research, and I suppose coming away today, is the importance of combining it with good qualitative research. I think the power for me is in the mixed methods. So when we looked at the qualitative work and we followed families over the year, it really matched up with the quality of life scores. So I feel terrible as my child does not sleep at night. I can't sleep at night. I feel really bad and tired, and I don't get help with my child. A lot of my relatives and neighbours make remarks about my child. This is the result of their sins. Why do you need to take care of him? So massive issues of stigma, massive issues of isolation. And I think that's probably where, you know, not doing the one-to-one work and just going visiting them on a one-to-one basis in the home, but the power of bringing together the parents as a group, that's probably where it made its biggest impact, was on that sharing and being able to tell your story. Some of the women said they hadn't told their story to anybody else, and that was the first time in a group that they felt they had a safe environment to tell their story. This is another case study to share. I mean, I hesitated about putting this one up, but I think it's a very powerful story to tell. And unfortunately, this child died just after the end of the study. And we wanted to make sure in our research that we also followed families who stopped coming to the training, because it's all very well and nice to follow up those who are coming regularly and understanding what they enjoy about the training. But we felt it was really important to also follow up and understand why people didn't. And I think that's often forgotten sometimes in the rush to do things. So this child was 9 years old, and apparently about a month old, just after birth, had suffered from severe fever and convulsions and had been diagnosed with epilepsy at that time. The doctor gave her some medicines, but I stopped giving the medicines to my child after 2 or 3 days. At that time, I thought such a small child could not have epilepsy, and that's why I stopped giving her the medicines. Incredibly poor family this, but we took him to 20 to 30 traditional healers for treatment. You can imagine the cost of that. So most people not receiving any kind of diagnosis. And malnourishment being a massive issue that we saw, and I think is certainly something that we want to do some more follow-up research around, because we did have 10 children out of 153 who died, and in most cases, the community worker said was often something malnutrition related. And that's important for us to understand better. And they allowed us to observe. So we also did half-day observations of this child, but it was important to use a local researcher, not someone like me, you know, bobbing in from London and checking, although I did the baseline interviews on this child. So we used a local research. You got to know the families over the year, and that was very powerful for our research in trying linking things up. And they were quite happy for that researcher to come and sit and observe that child lying outside all day, often in the sun, in urine, and neglected. So it's perhaps not totally surprising that unfortunately he died just after the study finished. They stopped coming and we couldn't get them to come to the training courses or engage with the services. So I think a big issue that came out and linked in again was this lack of time and isolation. This is the mother of that child who died. I work at the pottery all day long. I have to cook food 3 times a day. My father-in-law's ill. I have to take care of him. I have to work on the sharecropping. My husband sometimes helps me a bit in the household, but he doesn't help caring for me, and he has no interest in the child. And that was also observed and noted in the observation. I feel stressed working so much at home. I never get the time to relax. I feel bad caring for the child, etc., etc. So it was very powerful, those of you who are interested in the qualitative work, to see how it links in. I just put this in as a very positive case study because this was a child that we might have originally not included in the study. He was 12 years old, and also he had cerebral palsy, but it was more the intellectual. His problems were more a cognitive impairment. He had some, he could speak a little bit. He was intellectually impaired. He needed help with all aspects of self-care. And he would suck his fingers continually, and as a result he was covered in sores and then flies, and apparently none of the children would come near him. So he's quite a sorry state when we did the baseline interview. And his mum was very shy, and by the end she was a really active member of her parent group. And she said at the end he used to drool a lot, but now through the training he's learned how to swallow and wash his face. He used to put his fingers inside the mouth, but now we've shown how to encourage him not to do it, and the infections in his hands and mouth have decreased dramatically. He's now been able to communicate when he needs the toilet and also when he's hungry. I don't think we quite got there on that one because it was quite interesting. We had a lovely Australian occupational therapist working with us for a bit, and she worked with him is that in Bangladesh, you normally, I'm going to get it this wrong way around, you normally eat with your right hand. And he could have eaten with his left hand, but they wouldn't allow him to. So there were cultural issues there that we still need to get round and address. And we also didn't manage to address the issue of schooling, which we found was a real priority for all the children. Right at the end, we did some focus groups with the parents to understand what they thought they got out of it most. And I don't know if any of you are familiar with what they call the most significant change methodology. Anyway, it's a very popular tool to really get at what people think are the most significant changes for them. And I think the biggest one was having this stronger network of other caregivers and being able to better support each other. Because the reality is you're going to be in and out, and then they're going to be left in somewhere like rural Bangladesh. Increased knowledge, confidence in caring for their children, increased confidence in sharing that information. So I've come to know most of the parents through going through the training. Before training, they were unknown to me. And that was in their own villages. That was amazing. And whenever we hear about a child improving, we meet at their home and try to find out more. So there was, I'm not saying it changed everybody's attitude, and that would be a wrong thing to say after only a year. But hopefully that's the beginning of a longer change. And just something I want to add in is that right at the beginning, I was brought in after the project was designed, and there was no research with the children. I thought it was quite interesting that the focus was on interviewing the caregivers and the staff and the therapists. And I said, yeah, but what about the children? What do they think about all this training and this course? So we did some participatory interviews, any of you interested in that? And we used something called a feeling dice, which was, you can do it in different ways, but this dice, we were lucky enough to get these large, colourful, very soft, tactile dice, and they actually had little mini whiteboards on them. And so the children could draw their own smiley faces or sad faces or frustrated faces. And we were able to adapt it for children with different communication needs. And, you know, they had different priorities from their parents. So it was quite interesting. We're developing a training tool for parents, but they had very different priorities for parents. So there was real emphasis on play, real emphasis on going to school. That wasn't part of our original package. They didn't care, to be honest, whether they walked correctly or they could pick up their pen, but they wanted to be able to get to school, to play with other children. And they were the drivers. What was interesting, they were the drivers in getting their parents to go to the training sessions, not the parents themselves. So I think just to flag up there that, you know, it's important to try and remember them. So this one, my mother now can't take me to school regularly. When she's sick, she can't take me. If I was healthy, then my mother would not have to take me to school. When I see the pain of my mother, I feel like leaving school. And she carried on in the same vein. 1 month ago, my mother gave birth to a baby, and since then, my mother can't take me to school. So the emphasis there and the learning from that is, if that's the case, what can we do at a community level to support that child accessing school? So the result is this training package that's free to download from our website. All we ask is that people give us a little bit of information about how they're going to use it. It's modular, so people can look at it. It's very visual, very simple to use. Evaluating your child, positioning and carrying, communication, feeding, everyday activities, play. And, you know, we had a multidisciplinary team of speech and language therapists and physios and OTs involved in it. But it was getting it down to, you know, how can you translate that into something that's suitable for parents and that can be used by parents? So I think my job was often, I mean, I'm not a therapist, but it was like saying, what's the minimum? You know, can we get that into a language that is understandable to parents, and how can we do it in a participatory way? So it has proved incredibly popular, and that's a bit. And in throughout the manual, what we've done with the research is there's green boxes, and we've just illustrated throughout research that illustrates how we've arrived at that particular module, what's the evidence, what have we found has worked well and hasn't. So where next? I was sent this fantastic photo last Monday when I was feeling a bit fed up about work, writing up my qualitative work from Cameroon, and it came from Ghana. And they said that I received it from an organisation who are using the training material, and they said it's just going from strength to strength, and they've been able to link up with another organisation, which is lovely. And because of that, we've just got a tiny bit of money to set up something called a community of practice, but a kind of community network. We want to link these 150 or so organisations. You know, for all sorts of reasons. It will be interesting for a research point of view, but just even translations, you know, sharing. We've been able to link up organisations in Latin America so that they've all shared towards paying for a translation of the Spanish version. But I think much more than that, there are some adaptations of the material going on in Uganda, and we'll hopefully get some feedback from Uganda from a fantastic and passionate speech and language therapist who's using it out there. So she sent me, these are some pictures from Uganda, northern Uganda, where she's using the material. And I just added on one last thing about challenges. I was thinking, because that was partly the title of the talk, about challenges of doing research in low and middle income countries. I think one of the issues for research, from my perspective coming into this project, finances. I just thought it was very interesting. It's quite hard to get money for research and disability, but I think Isla's right. I think it's changing. I think the climate is changing slowly, and I think that the international inquiry going on for DFID, I hope, will change for people working in international development. I think one of the challenges in any of your project is working. You know, it's very hard to get therapists. I've just come back from Cameroon. There is no training for physios or speech and language therapists or OTs. So, you know, that's a challenge if you're wanting to do research related to rehab. And I found from Bangladesh, it was quite interesting this idea of empowering community workers and parents. Those limited number of therapists were a little bit reluctant sometimes to give up some of their expertise because they had fought hard. They might have been the first physio who was trained in that country, and actually that comes with a status and everything else. That was quite an interesting one in Bangladesh. And I think, you know, needing to look outside the box sometimes in the local context and finding something that's relevant to that cultural context. And just from a research point of view, because I'm a qualitative person, you know, the mixed methods is really valuable. I don't think without the in-depth qualitative work combined with the quality of life measures, we wouldn't have had such a rich, full picture of their lives. And I don't think that the material would have been as relevant, and the case study material that we've illustrated throughout, I don't think would have been as attractive to people. We've really been able to use it, and I'm sure that's one of the reasons why it's quite popular, and I really am going to stop at that point.